virus and women's health in HIV within the treatment and care team of the global HIV, hepatitis, and STI programs at the WHO headquarters in Geneva. Adolescent health. Help me welcome Dr.
So wait, I know to do.
Moko Newman Awelu. You thought I forgot the name. So I'm privileged to be co-chairing with her, my humble self. I don't think I need an introduction. So we'll go straight to Dr. Newman to start the program. Thank you very much.
Good morning, everyone. And he thinks he doesn't need an introduction, but I think he does. He's the program manager for the National AIDS and STI Control Program here in Ghana. And that's Dr. Emmanuel Tigri, also a public health physician. So we're really excited to be here today because we are dealing with a particularly important topic, which is, as he said, leveraging digital health innovations. And we are doing this in the context particularly of eliminating mother-to-child or vertical transmission of HIV. I'd like to welcome you all, and we promise you a very exciting session. Please don't hesitate to put on your questions because we definitely will have some time for discussion, and we will give you as much information as we can, depending.
No, I want to reconnect again. Don't worry.
So I will then call Dr. Every to kindly inform the participants about the translation services.
I thought you would clap for chair. Yes, so as we are all aware, this is an international conference, and so adequate provision has been made for inclusivity in terms of translation. Courtesy the conference, interpretation is available in over 50 languages. Is that not great? 50 languages. So you can access that online. Online participants, a QR code link is also available. You may select your preferred language and then mute the original audio if desired. In-person participants, QR codes are also available at entry points. So please scan and select your preferred language. If you have your earpiece headphones, you can use that. Be able to listen to the translation. Now, important side attraction, participants at the end of this session will benefit from a bar of Ghanaian chocolate. Oh, who gave it to them? We should have waited to see those who actively participated, then we reward them. But this is just a sign to welcome you to Ghana and to the session. So at this juncture, I think I will hand over to the chair to take us through the objectives of the session. Thank you very much.
So the objectives of this session, we'll be looking or examining the role of digital innovations in sustaining the gains towards epidemic control. The second objective is able to share Ghana's experience on integrating and scaling up digital health tools within our national programs. We also will identify the key challenges and opportunities for sustainable digital transformation in public health. The structure of this session Basically, we will have our presentations and then a particularly interesting panel discussion. We promise it to be very exciting. And then after that, we'll have the interactive session with you, the audience. So we hope you pay attention and really ask us questions which will get us thinking and planning to improve digital health, not just in the MTC, but as much as possible integration. So I'd like to call on Mr. Philip Wachi, who will give us the digital health information and progress towards HIV. He will give us an overview of the national digital system in response of children's challenges and investments. Mr. Wachi is a laboratory information systems specialist within the AIDS Monitoring Program. Welcome.
Good morning to everyone. So, so we are going to talk about Ghana's digital innovation for HIV epidemic control. Before we start, let us quickly look at where we stand as a country in terms of HIV response. So we currently have 334,225 people with HIV in Ghana, and we recorded 15,219 new HIV infections, and then 12,614 HIV/AIDS related deaths in 2024. Against the 95, 95, 25 targets, we are currently at 68, 69, and the 90%. So if you check, the HIV viral load looks very strong. In terms of adult ART prevalence rate, we are at 1.49%. So with these realities, it became a necessity for us to put in some interventions to be able to improve our national response. Since that we have 5 is offline e-tracker system, and this offline e-tracker system basically DHIS2 tracker. And then we also have the bunch of care technologies, barcode labeling, the viral load management system in short VLDs, and then e-learning platforms. Next slide, please. Okay, so let me give you details about the offline e-tracker system. So we faced many challenges, just like many other African countries here. I mean, paper-based records got lost, lab test results delayed, and there were also issues in terms of tracking clients who move between facilities. And then most importantly, where internet connectivity was a challenge. So the offline version of the e-tracker or the DHIS was introduced to bridge these gaps. So now health service providers at the ART clinics or centers are able to enter data offline, and then the system sends the data when internet becomes available. And this has actually reduced runtime for patients and also loss of follow-up. In terms of point of care technologies, this was also introduced because turnaround time for EID and viral tests used to be weeks and even sometimes months. So the GeneSpect technology, that's a POC, was introduced in 143 remote and high bearing sites, basically to reduce the turnaround time and also improve testing coverage. And as we speak now, EID results return within less than 24 hours, and then the viral test results the same day, since most of these facilities have the machine at the facility level. So once they run, they get the results the same day. Next slide. So with the value data management system, before this intervention, all our records in terms of results were actually paper-based. So this was introduced more or less to replace the paper-based systems. And so now when you go to the ALT centers, they have this VLDMS, which was developed or built within the DHIS2. So it's embedded within the DHIS2. So users at the ALT sites have they capture those of us who are familiar with the DHIS2 to enter via the request. And then also use the same capture to check the individual results. And then the line listing app is also available for them to check for bulk, more than one patient results. And when you go to the testing labs, we have another software we call interface client or the middleware. So this software connects the analyzers all over the country, all the testing labs, and we are able to transmit the results to the ALT clinics within the shortest possible time, the same day. Once they run, because they are integrated with the DHIS2 system and it is online, users are able to access the results within the shortest possible time. And this has actually improved or enhanced the virus suppression rates, because within the DHIS, we are able to analyze the data and see where we are going into in terms of treatment failures and all of that. Next slide, please. The value data management system, one of the key things that we use in terms of results transmission is a specimen ID, what we call the unique identifier. This unique identifier, when we started, was actually manual. In other words, users needed to enter the specimen ID, but there were errors. So introduce this intervention with the barcode, sample barcode, labeling and scanning. So at the ALT sites currently, they are able to scan the barcode label, and this has a specimen ID embedded. So the specimen ID appears on the e-tracker automatically, and then they see. So when it gets to a testing lab, because the analyzers, both the gene expert and the conventional classroom, they also have the capacity of scanning our labels. They don't also enter the specimen IDs manually. However, they are able to, the machine is able to scan, and within the same day, they get the results. Next slide, please. Now, these 5 interventions that we put in place, in terms of impact, we have actually improved data quality. So now the 95 reporting, the 69, 69, 90 reporting has actually improved in terms of data quality. And also there's a cost savings, because now the other intervention, which is the e-learning platform, users, we are able to are able to log in and then at their own self-page have themselves trained. And we are all aware of staff attrition. So even if you do conduct capacity build or training at the facility level, you will not be able to do it all the time. And so once there's an e-learning platform, they are able to go there and then have themselves trained. And this has reduced operational cost. And there's also efficiency, because within the shortest possible time, you have your results, if it is lab test from the gene expert or the other conventional classrooms. And there's also some level of satisfaction from the staff, because now their work has actually improved, and in terms of retention has also improved. Next slide, please. Now let's talk about lessons learned. One of the key challenges, before we started these interventions was actually infrastructure and connectivity, especially in the rural areas where electricity and then internet connectivity was a challenge. So we were able to put in place the offline, and that actually addressed the problem. Now, users, it's not easy for them to actually adapt within the shortest possible time. And here we are referring to change management. But through continuous training, they were able to adapt, and now they are comfortable with the electronic systems or the digital interventions that we have in place. And also data security was also a concern. That if we are being online, are people not going to have access to our data? But because of the security that we have in place in terms of access levels and all of that,
the client data has now become confidential, and there's no consent. And then also, in terms of critical successes that we have chalked, we were able to chalk these successes because of the strong leadership and right from the Ghana Health Service leadership at the NACP level. And then also, in terms of users, the user-centered design, always taking feedback from users, making sure that the system is actually configured to meet their needs. And then the partnership, which is also very critical in terms of collaboration with partners such as UNICEF and the rest, we're able to align with our national strategy, and that has, in a long way, prevented duplications, because we were always trying to avoid having parallel systems. And the capacity building investment has actually helped with the e-learning, the mentorship, the on-site supportive supervision. And then the last one is the standardization, the interoperability, where we needed to connect the middleware and the testing lab to the e-tracker for them to use. In terms of sustainability, sustainability can always happen with these three things. And one is institutionalization, financing, and the local capacity. So we have integrated our system into the Ghana Health Service systems, which is the NIMS2 or the DHIS2. And we also have a budget line in our national budget so that there's always resources available to expand. And in terms of financing, we are also transitioning to donor independence, to the government ownership, and also trying to explore other innovative way of financing some of these digital systems. The local capacity is also very critical. We are working with our universities to see how we can work together to expand some of these innovations, and also engagement with youth in digital health solutions. Next slide. Okay, so I would want to end by thanking these partners: NACP, the Ghana Health Service, the Ministry of Health, the Unity Commission, UNICEF, UNAIDS, World Health Organization, the Global Fund, and then the PEFA. Thank you.
I think we can do better for Flip. Very nice and crisp presentation. Talking about how we can leverage digital innovations to improve service delivery and satisfy our clients. Leadership is key at all levels, and this has been demonstrated by this result. Once again, let's give it a round of applause. Very well. So, next presentation from our partner and collaborator, UNICEF, will be done by Dr. Paul Giannakedo, which will focus on partnership to support country mechanisms for piloting and scaling up digital innovations. So let's give it up for Paul. Dr. Paul. So Dr. Paul is an epidemiologist who works with UNICEF as a health specialist on HIV, TB, and gender responsive issues, including adolescent health programs at the UNICEF Country Office. And also is a specialist in health system strengthening through community initiatives. So Paul will now take us through his presentation. Let's welcome him once again.
Thank you very much. Good morning to all of you. Thank you for coming for this. So I'll be talking to you about the partnerships that we went through to introduce these innovations in Ghana's HIV response. If you look at the global HIV epidemic and the onset of the COVID pandemic, laboratory systems became quite a challenging situation, and we had to rethink how we were going to handle this. We know that without treatment, about 50% of HIV-infected children globally would die by the second year of life, and the peak mortality is about the 3rd to 4th month. And then, so you know, the tightly linkage to care, that is the exposed infants being tested and having all the interventions until they are cleared. It's very important to save the life of the child, whether the child tests us as negative or positive. Now, in Ghana's situation, only 33% and 47% of infants exposed to HIV positive mothers in 2022 and 2021 respectively were tested for EID. That is very, we're not even reaching up to 50%. And then blood samples of mothers and babies had to be transported, especially from the rural areas. So we had a conventional testing sites located in major hospitals in the cities, a few cities. And so from far districts, you have to transport all of these are pulled to the center. They have to queue, tests have to be run, and results sent back. Now the challenge is if laboratory sample is inadequate, that sample would have queued for like a month or two and sent back and forth. So by the time the clinicians are getting the results for EID or even viral load of mothers, sometimes it's past 3 months. So it took for us beyond 90 days to 6 months for babies to get their results. Sometimes results are not get back because if let's say sample is not adequate, the report doesn't get back to the site on time, and it may take forever without a sample. So this caused a lot of agitation among mothers. They were very anxious. Clinicians were very distressed because they couldn't take the initial action. It affected our overall mortality among newborns. So partners including PEPFAR, WHO, UNICEF, and of course the Ghana Health Service and Ghana AIDS Commission. We engaged on an assessment of our diagnostic capacity, and we realized that although the country was very well prepared, Ghana has about 262 districts and almost about 160 had gene spec machines. Now we tried to see how were these machines optimized, and we realized that only 107, well, up to 107 were just about 25% optimized when it came to the usage for TB, HIV, EID, viral load, and COVID-19. And just about 5 out of all of these laboratories were up to 85% utilized to handle all the spectrum, of diseases. Next slide. So the next network optimization was to look at decentralizing the testing from the PCR sites to the district. And how do we move from conventional PCR machines to using the GNSS machines to adequately test for tuberculosis, HIV viral load, and early infant diagnosis. And the idea was that district laboratories will remap to facilities within that zone. And Ghana's target was to ensure that at least within 50 kilometers, samples could travel within 50 kilometers. And that will reduce the transportation time. Now, this showed that if we're supposed to move onto this gene-expert point of care testing for EID, viral load, tuberculosis, it was going to save us up to 381,000 annually. And if you looked at the cost of cartridges to gene-expert machines and all in all, this model of point of care testing was going to save the country over $200,000 annually. So UNICEF's focus was to ensure that we have a data-driven optimization of our diagnostic system, and then to strengthen the health systems, especially data systems, and then also to ensure demand creation, because most mothers now lost trust. Mothers who had babies and gone through all this stress, were no more excited because the thoughts that your baby's blood has been taken to Accra, over 5 hours drive, and you don't know the results after 6 months. Some people thought that their baby's blood was being used for rituals. And so these are really challenging times. We're hoping that we could bridge this gap to ensure demand creation. And this is what was used to happen. So we chose the Eastern region, and after several analysis with the National AIDS Control Program. And the red spot is the capital city. Now, these are just 14 sites. So all of these have to travel. If you look at the map, you see all the way the river, water, lake. So some samples even have to travel across lakes, before they get into the capital, and the results now sent back. What was going to happen was that the blue spots, which are the districts with GNSS machines, could now do their own testing. So samples would be taken within that district and sent. this will reduce transportation time. It's empowered the community level testing, because now testing was no more typical laboratory based. I mean, sampling was not laboratory based. Now we're taking at community level. Now, what this one we realized between 2021 and 2022. So, as of 2020, the numbers of testing for EID was as low as below 100 numbers, and the viral load just about 200. You see a sharp rise from 2020 to 2021 when this initiative was started, along to 2022. Turnaround time, like Philip had mentioned, was quite high, but now we're registering within 24 hours to 5 days. Babies will get a sample, then relieve anxiety, clinicians will get their results much earlier, and interventions will start much quicker. And almost by 2022, 100% of all exposed infants in the pilot districts were being tested. Now, this evidence, was like more like a proof of concept, and this evidence drove the Global Fund now to support with cartridges, support with logistics for this EID and viral load. And it's also informed partners like the WHO, PEPFAR, to support the scaling up of this across the country. And this has also informed the barcode. So as we got into this, it's informed the barcode labeling on samples, which is going to bridge a gap of data transmission, as well as configuring the GNSS machines at the district levels into the e-tracker, so that as soon as you scan a sample, the barcode results move straight into the e-tracker. Any testing results straight into the e-tracker, and the clinicians at the testing site real time will get the results of the baby. That takes away all the errors of data transmission as well that comes with human intervention. So I'd like to appreciate all these partners, and thank you very much for all this.
Thank you very much, Paul. That was a particularly interesting presentation, and I hope you all appreciated the difference that has happened since the innovation was first brought on board. I think it's important that we have this at the back of our minds even before we ask our questions. We've looked at data, information systems. We've also looked at the service provision. That he actually mentioned the recipients of care, and they are probably the most important people we should consider here. So our next item is the panel discussion, and we'll be talking about sustaining and scaling these digital solutions for impact, HIV impact. Now our panelists will be, in fact, they are on the table with me, on the floor with me right now. We have first Philip. We'll ask Philip questions. We'll also ask questions. And then lastly, we'll meet Sandra, address recipient of care. And she has some very interesting experiences to share with us. So immediately we'll go into this. Please write down any questions you have, because I think there will be time for discussion. So we'll start with UNICEF.
Yeah, this one, your translation.
So we want to also invite to the podium Dr. Deputy Program Manager, National Base President. He has a repository of knowledge on all these cross-cutting issues, so that you can make some interventions.
It's not unnecessary. The link.
Okay.
He likes fun, so clap well.
So please direct, during the discussion, do not forget to direct questions to Ashina as well.
Mine is on the platform.
So the first question will go to UNICEF. I would like you to give us some information about the donor perspective on supporting these digital innovation and sustainability issues. We know you spoke to it in your presentation, but it's important for us that we also look at integration. How is it that we can use integration to ensure that we do the scale up? And we know you'll be speaking not just for UNICEF, but for all the partners who have supported this. So all over to you.
Thank you very much. I think one of the things that the massive challenge when it comes to pilots and something is how do you take it to scale? Because there's no point piloting anything that you can't take to scale. And that raises the question of how does it integrate into existing structures? So we at Harvard Institute have quite extensive structures, data structures, laboratory systems. Tuberculosis control program had procured enough genes with machines, very beneficial during COVID-19. And so the conversation of integration has to do, first of all, with the existing structures that is in the country that partners can leverage on. And what is available in the country and how to leverage on them. The pilots, again, the issue of integration has to do with ensuring data-driven pilots. You need to ensure that there's good analysis to make a case for that pilot so that you can take it to scale in the country. It is only that you can even have a conversation of sustainability of that particular pilot who's going to scale. And we are very proud to say that what we've done, although started from 5 districts, now it's across most parts of the country. In some areas, it actually becomes the only mode of testing, where they are very far from conventional PCR sites. It becomes a mode of testing largely. So these are the two key areas: data driven and ensuring sustainability through the system of existing programs.
Thank you very much for very important points. Data-driven implementation for me is probably what is most important as we speak. And that brings us to Philip, who is our information man. And we will be asking you about barriers in system interoperability, user adoption, and data privacy, which you talked about. But maybe give us a little more emphasis on that. But also, what do you see as the opportunities for public-private partnerships and the digital sustainability? Thank you.
Okay, thank you very much. So, we'll start with the barriers. Just like many other countries today, we face a lot of barriers in terms of adoption, user privacy, and all of that. However, we were able to address these challenges with support from the national level, in terms of leadership and all of that. When we started, in terms of interoperability, the ground management system, for example, the module that we have at the testing lab didn't have, it was not designed to send data to an online system like the DHIS2. So because we wanted to meet the national standards, making sure that we are able to transmit results through the intranet to the ALT sites within the shortest possible time, we were able to make some changes to be able to address the challenge of people having to wait for days before they get their results. And then when we started, the users thought that this system more or less is coming to review whatever they were doing in terms of paper-based system, because there was only visibility and people will have access to the system irrespective of where they find themselves. So even if we're in the US, you might just online, you can check your value results, you can check your data and all of that. And so with continuous training capacity building, we're able to address these things. And let me also add on in terms of sustainability and private partnership. We believe that we can only sustain these digital interventions having embraced the national ownership, which is very critical, and then also financing and needed resources for us to be able to sustain the resources.
areas of software development, maintenance, so that we don't actually, create para systems from universities, but then having to work together to meet the Ghana Health Service standards, and then also integrating these systems so that they can all address similar um, challenges. Thank you.
Maybe just to add that, especially with our e-learning platforms, because we have had with the regulators of the professions, nurses, pharmacists, and the doctors, and so on. The e-platform has now been accredited with credit quality. Use the platform so that with that it's not money as well. Once everybody so we get the school now is such that we are able to get a lot, thousands of people trained with some small amount of money. So this is one of the success stories that we need to carry. Thank you very much. Sorry. And raise points again that we need to really remember when it comes to innovation, the difference it can make. And we are next going to talk about the difference that it can make, or the difference that it has made in the special life who is here. In fact, 1.5 guests, as you can see. And recipient of care, Ajah, going to speak to us today. Just a bit about her story. She actually knew her status before pregnancy, so very good prognosis, very likely that PMTCT will be successful. And she has had 2 children. She will tell us a bit about the experiences with the healthcare system before and then after this innovation which we are discussing today. Her first child, she'll tell you, is talking about the final status being known when the child was 1.5 years. And then the different story with the second child. We are going to speak English because she speaks Tree mostly. I am not good at Tree, but I'm the translator for today. So anything can happen. And I'll be supported by Dr. TV. So she's going to tell us a bit about how she felt, how she reacted in both cases. That's before and after the invasion. So, I don't over to you.
HIV status before pregnancy. I am a drinking because now I can say, yeah, a balance of it in the now, the movie, Mrs. Phonic actually say, a balana ona 6 weeks out, then obey love. See, time to do it, the love. One catch every 7 call. Love me bomb best friend. Me buy me buy maybe salad no say ready. For almost 1.5 years, that me up another 1.5 year test no. And some no catch me say results number. But before then, anytime I plan be results in buying. Anytime I plan be an amadi and say I plan in ya really. Especially so not diarrhea. Young to me she because if you say not apalana the egg why do you say ya really na winner? But my second born, the one the love. year now, 3 days for the and the results by let's say negative. It's no system not with the abana, why yeah, apart time people and I that process.
Thank you very much. So what I trust says is that, like you said, she knew her status before, and she was particularly stressed about whether there would be transmission to her baby. However, she was told to do the lab test at 6 weeks, and she did go to the hospital, but then getting the results was a real challenge. And she did not get any results until the child who did the 1.5 year test. So you can imagine the time that she had. Like she said, each time the child was ill, she felt that